Good morning, everyone. Thank you for the invitation. And I'm going to talk about something specific. As Joy said, most units make use of the intravenous route, but there is also the option of intra-tumoural injection electrochemotherapy. And I want to talk a bit about that and talk about the rationale and some decision making with regards to that. And it's also based on the discussion we've just had, where there are benefits with regards to that. Everything has a start, and from the clinical side, the start of electrochemotherapy was the ESOPE trial, where Julie and other people have been involved with. And at the time, they've also written a standard operating procedure, protocol, which was very much based on the trial situation, but is used as a guide for many units starting. And as we are using electrochemotherapy more, learning more about using it for different indications, so the SOP is also changing and evolving, and Joy will talk about that later. There is a formula that you can use, and you can measure the nodule that you're going to treat, work out the volume, and then based on that, the dose. We did that right at the beginning, but we don't do it anymore. You want to get as much of the drug into the tumour as possible. It's not that difficult. You inject it until it blanches, until there's pressure, until there's turgor. The same with the margin. And when we had a meeting in Inspect recently and took a poll about it, most people that use intralesional bleomycin don't necessarily go and calculate the dose specifically for each nodule, which can be cumbersome. And I don't think it's necessarily necessary, and you can do either or. Just a sec, sorry about that. So, I don't know whether some of you remember this machine, which was one of the precursors to the one that we've had. And there is an evolving situation. We are learning more. We were all younger then too, and this is the newer machine, newer technology. And I think the thing to do is that these meetings are important to share our experience, what we learn, and as things develop, so that we keep track of that and keep each other informed of the good and also the bad. I think it's important to know about side effects, complications, so that we share that knowledge. Now I want to show you a little bit about the demographics, because it's something that might happen to other units or might have already happened. You'll see right on the left in 2007, that's when we started as the only unit in the UK doing electrochemotherapy, and it was basically just me and Alison Humphreys, the oncologist, and we did 14 cases in that year. And then there was a gradual growth, slowly ticking along, as it took time for the treatment to gain credibility, to publish results, to show local outcomes. And also, as Joy said, that NICE guidelines and so on have made a difference. And in 2014, we treated 46 patients. Last year, 88, so there's been a sudden jump. And then you can kind of look at it month by month. So in October of last year, we treated 10 patients. I've highlighted the basal cell cancer column. In November, 9, and you can see there's more basal cell cancer patients. December, 11, and again, most of them basal cell cancers. 12 in January, and 17 treatments in February. A lot of them attributed to the basal cell cancer situation. And what's important is that the average treatments that we do per month has trebled, and I think that's important logistically, because these patients are referred not electively. They often are either on a cancer pathway, and you obviously want to treat them as soon as possible. So you need to see them somewhere, unless you can plan an electrochemotherapy clinic slot. And then, of course, you have to treat them quite soon as well. So I think that's something to be aware of in planning a service. And most of us, before we take ECT on, already have quite a full, we're normally wall to wall, isn't it? So, and then this comes on top of that. So I think that's something to bear in mind. So the benefits of intravenous electrochemotherapy, as Joy has shown, is you can treat large areas, large tumours, So the drug's given, and then it depends on you to electroporate as much as is needed. And it's also very useful in multiple lesions. And as sometimes you've seen, I'm sure some patients have literally hundreds of lesions sometimes. The drawbacks is that unless you're an oncologist doing the treatment, you need to have a colleague that either sees the patient jointly, if you can manage that, or separately, which means a double consultation, because the oncologist that's prescribing the intravenous bleomycin would prefer to see the patient in person, and then you need someone to administer the bleomycin. Now, we're lucky that our skin cancer nurse, Caroline, is also trained as a chemo administration nurse, so that helps. But then the two of us also need to be in theatre at the same time. Treatment is much longer because you need to site the second cannula, you then need to run in the bleo, and then wait for 8 minutes, which I find very frustrating, before you can even start to do something, which significantly lengthens the procedure. There is a higher administered dose, which we talked about, so the patient gets a full whack of the intravenous dose, where we are actually providing a localized treatment, where the effect is only where we're going to electroporate. And we're not exactly sure how much of the drug will reach the end point. It's a lot of things that will happen from the intravenous infusion until it eventually reaches the target point, and there's also a timing as to when we pulse with that. The benefits of intratumoral electrochemotherapy is you're sure that there is a high intratumoral concentration because you inject it, you also control the time, and I'll show you something about that and why that's important. More significantly, it's a lower dose. You only put in as much of the drug as is needed, and with a lower concentration in the normal tissues, there's lower risk of systemic side effects for the patient, and the treatment is also much quicker. The effectiveness of ECT depends on the extracellular drug concentration at the time of the pulse, and then the electric field, depending on the electrode that you're using. Now, bleomycin is a very old drug, and it is very effective in cutting DNA, even compared to some of the newer cancer drugs, and so much so that it's even received renewed interest. And this is the Biodesign Institute in Arizona, where they've kind of looked at it from a new perspective. And not only does it break the DNA on multiple places on both sides of the strand, but it also reactivates and keeps on cutting. And that is why we can see pretty good responses in the correct patients, despite other treatments sometimes not always being able to address the problem. Now, this is a slide from Gregor Sersa, and we know this is the same for bleomycin. If you look at the cure rate, don't have a cursor, do we? I'll use this. So, if you look at the cure rate on there with cisplatin, and it's the same for bleomycin only, because of the low intracellular transfer, the cure rate and the tumor growth delay is low, and this is in EAT tumors in mice, and there's a significant increase of both the cure rate and the tumor growth delay with electroporation, with a combination, which is obviously why we do this. They very carefully looked at the timing, and this is for intratumoral injection, and you can see that the cure rate is the highest just before or at the time of the pulse, and the same with the tumor growth delay. So the best time is in 5 minutes before the pulse is applied, or at the time of the pulse, and the cure rates are much lower later, before and or after that time. And with intratumoral treatment, you control that. You know when the drug is going in and when you're going to pulse, so you can actually optimize that situation. And then looking at the tumor growth delay in intravenous versus intratumoral electrochemotherapy in EAT tumors, there is a higher response rate, but I think there's more work to be done in a clinical situation to properly look at this. So how do we decide when you see a patient? What are the things to make you consider intratumoral bleomycin versus intravenous. So this is a young boy, he's 19, he's got a recurrent keloid. It's a single nodule, and my preference for him would be to absolutely opt for intralesional bleomycin. Otherwise, you're going to administer a big dose for a benign condition, regardless of his age. You're not sure how much of the drug is going to be absorbed into the scar tissue. You can very accurately infiltrate that, inject it, and make sure that there's a high concentration in the keloid. And then, as Joy said, we would treat with either a linear, and if it's smaller, a finger electrode, because you would want to get this to regress without significant ulceration. This lady has a basal cell cancer, a single nodule, and I think it's the same thought process. You can almost consider this as a benign condition, because we're used to treating palliatively, patients with horrible tumours, but the electrochemotherapy is applied to different pathologies. And in this patient, I think giving a full intravenous dose, apart from the risks and the accumulation, you can accurately inject this intratumorally. We would treat with either a finger electrode, or if it's bigger, a needle electrode. And she's had one treatment, and that's a close-up. Now this gentleman has got 2 basal cell cancers. He's left them happily for 15 years, and then eventually came to see us. And again, we are limited to 15 milligrams, or 15,000 international units of bleomycin in a syringe. So you can give up to 15 milligrams of the drug when injecting. And for him, we opted to inject this intratumorally, and he's had one treatment and a second, and that's a later follow-up, and that's the basal cell cancer on his forehead and on the medial canthus, and a follow-up with very low morbidity, very good aesthetic outcome. I don't think it'll be an option in a small basal cell cancer that you can excise. It's much better to just excise it. If you need to do a skin graft or a flap, then I think, especially if it's in a critical site, then it's something to consider. And at the moment, although the numbers are high, we are not offering electrochemotherapy to any patient with basal cell cancer. The patients that are treated are patients that have said, I'm not happy with the operation or the scarring that you're considering, I'm not keen to have radiotherapy. So it's an option of exclusion to a degree. This is a single nodule in a patient with malignant melanoma that's been treated, and again, a single nodule like that, you can inject that intratumorally. You'll get a low dose. You'll probably inject about 3 milligrams of bleomycin into that, a linear electrode, and that's after the treatment. If it's a pigmented nodule that you treat with electrochemotherapy, the pigment remains. So the nodule kind of just collapses down, but the staining often stays there. So it's not necessarily a sign that the treatment didn't work, it's just that the pigment stays within the skin. So this is a bit more debatable. This is a frail lady. She's in her 90s, and she's got melanoma metastases here, and here, and another one there. And she's kind of on the limit. You can probably still inject all of them, or you can give her intravenous infusion, but that's going to make her general anesthetic much longer. So for her, we treated her with intratumoral bleomycin, and we just used the dose, and it was enough. Because of thin skin, she developed a fair bit of crusting, as Joyce talked about, but then a good outcome for her. And you're not treating the systemic disease, but for her, that means that those nodules would not continue to grow and become a significant issue. And this is a no-brainer. So this is the patient where you'd want to give her an intravenous infusion and treat the area. And the same with this patient with the inflammatory breast cancer. And this is after we've treated her. And that's before and after. And this was a hexagonal electrode. And again, Joyce talked about this. You do get hyperpigmentation. This patient isn't concerned about that because you're treating cancer, but I think if you use a hexagonal electrode in the face, especially for things like a keloid or something benign, then it might be an issue. So the pigmentation, I think, is an important thing. And then you can see that she came back because she developed a new nodule here and a small area there. And in this scenario, we would treat that with intralesional bleomycin. Local anesthesia, Gareth's going to talk about that later, about the anesthetic implications, rather than give a full intravenous dose for that. What I do for most of my clinical work is I treat vascular anomalies with ultrasound-guided sclerotherapy. So I use ultrasound every day, and I think the one thing I wanted to show you is that it's very useful in cancer and in electrochemotherapy. There's no benefit if it's an intracutaneous tumour, but for subcutaneous tumours, you can get a very good view, a very good assessment of where the mass is. And this is a subcutaneous malignant melanoma metastases. And if you look at this, you can see there's a lot of debris on the inside there. So there's necrosis, there's kind of a soup. And if you imagine that, and if you give an intravenous infusion, you're not always sure how much of the drug is going to actually get into that nodule and diffuse through all of it. Under ultrasound guidance, you can place the needle and see what you're doing. And then this is one of my regrets, because if you inject the drug, you can see it fill the tumour, you can see it move around, and you can also see if there are quiet areas, and I should have taken a video of that, but I'm sure you've been in that boat also, where you just forget to do it at the time. But it means that you can very accurately make sure that you are filling the tumour and injecting all areas. And as you can see, this is a palliative situation, so this is a groin node, 4 centimetres deep. The needle's only 3 centimetres long, so we won't be able to treat this patient curatively. Again, because we were treating the rest intratumorally, we also did the same and injected into this tumour with ultrasound guidance, and you can see that you're filling it. And there's also another benefit, and that is that you can see where the femoral vessels are, or even the chest wall. You can measure the thickness, and you can work out how deep to set the needles so that you can safely treat the tumour, but you don't press the needles into a vital structure. You can also hold the probe sideways and kind of see the needles go in and see where they are sitting, and it's not difficult to get radiology colleagues to be involved and help with this, and I think it can be a helpful situation for subcutaneous tumours. The shortcomings is that sometimes the drug will just leak out. You can't overdose the patient because you have a specific dose available, and you just try to get as much, probably use a smaller caliber needle so that you can inject into the tumour without it leaking out. But if a bit of it leaks out, it makes it a little bit more difficult to determine exactly how much of the drug you've put in. But it's not a complete contraindication. And then, of course, you might not inject the whole tumour evenly, and that might be one of the shortcomings. But I think it is something to consider and to think about, and especially for more benign indications, I think it should be something to strongly consider. And lastly, I want to show you just an interesting case. So this lady, it's a Merkel cell tumour, and she was referred to the head and neck plastic surgeon for excisional surgery for this. But in the 3 days before she came in, it started to just take off, and it doubled in size. And he rang me in clinic. I was on call the week, and I said, can you come down and have a look at this lady, because this tumour is bleeding. I don't think I can operate on it, and I'm not sure what we're going to do for her. And I looked at her, and I thought that we should treat her as an emergency. This was just waiting to start to bleed uncontrollably, and we admitted her overnight. there wasn't enough time to, I mean, you would consider giving her intravenous Bleomycin, but what we did is we took it to theatre. The next day we infiltrated with lignocaine and adrenaline and tumescent infiltration, and basically debulked the tumour, took it off with electrocautery, and then treated the base. And she stopped bleeding immediately. She stayed, because she was frail, she stayed on a few days on the ward, but then went back to the nursing home and had outpatient dressings. And this is when she came back a week later. And I already planned and discussed with her that I think we should treat this twice, because we want to try and knock the tumour back as much as we can. Otherwise it'll just do the same in the next coming weeks. And this was a week later when she came to see us. And we've kind of made a mark just around there as a margin, but she's got this eschar here, and she's got this part on the back. And we took the eschar off, and I was worried that underneath all of that would be active proliferating tumour, and it actually looked pretty okay, like a raw wound. We decided to treat her with intra-tumoural Bleomycin again, inject it into this area, but then we also inject it into the margin, and there's one area here that looked a little bit dodgy, and then this small nodule on her ear, retreated her. And that's the injection. We use a coloured syringe for the Bleomycin, and that just makes sure that you know which one is the cancer drug, because we often do combination treatments with local anaesthetic infiltration, and they all look the same, they're all clear. So it's a good way to make sure that the cancer drug is identified, and we'll see how she gets on. And that's me. Thank you.